like to invite Professor Dr. Krishna Sundari Madam and Dr. Major Karthikeyan Sir as a chairperson for the next session.
Good afternoon, everyone. On the outset, I thank the organizers and Dr. Shankar Subramaniam to bestow me with the honor of giving the oration on the name of Professor Mohan Kameshwaran Sir. Mohan Kameshwaran Sir is a mentor for a cochlear implant program of so many colleges throughout the Tamil Nadu. You can say he is a mentor of the cochlear implant program of the government hospitals in Tamil Nadu. And this talk is in the YouTube, where how the government cochlear implant program has started, where Sir was talking on the medical professionals are giving tribute to our late Chief Minister, where he was talking how the cochlear implant program gone into the mainstream. So you can see that in the internet. So you can see this in the net. It's a wonderful talk. He says about he showed the cochlear implant. He showed two videos. One child from America talking with their grandparents over the phone, while other child is talking with a sign language. He said, what has got from this fellow, this child has not got comfort this guy. Then our Kalanjar asked, what can I do to make this fellow also talk? There he said, give me money. So he gave the money. So there the cochlear implant program has come. So this has come to the, we can almost, you can see the implant program in Kallakurichi. It started in Stanley, Madras Medical College, all these places. It was started by our Mohan Sir. On his name, giving an oration, I am really proud. And this is another cochlear implant program where in Kallakurichi, Mohan Sir started the program where we all three of us were there. And this is where, when the first cochlear implant was done in Stanley Medical College. So in the theater, we took this photograph. You can see the childish Shankar Subramaniam, who was the first year PG then. So from there, he has come to this long distance, and individually he is doing a workshop come conference on a sleep surgery. So I thought I will talk about palatal surgery. Today morning you saw the barbed wire. So there are already you have seen so many the lectures, everything where everybody was talking about various definitions. What is OSA? So what are all the investigations you do, and how do you proceed? So when you suspect a patient with an OSA, you do a gold standard of investigation is this polysomnography. The days it has started like this, nowadays all these channels has come into single cables and wireless cables and things like that. And then the gold standard for management of gold standard for management of OSA is CPAP. There is no second thought about it. Unfortunately, the compliance for a CPAP is very, very less. There are a lot of contributory factors for that. One is the social stigma. When you have somebody is snoring in the train, next day morning everybody will come and ask him what happened, why are you you snoring like this. If he takes out a CPAP and wears that and sleep in the night, more people will come and ask him, what is this, what machine, what happened to, how is this comfortable or not. So your social embarrassment will not become all right with your CPAP. And you see, it is not very romantic. Young people can't wear a CPAP and sleep in the night. Third is, there are certain places like deviated nasal septum. There is a collapsing epiglottis. All these things will not give you good results for a CPAP compliance. And the pressure required will be more, so it will produce more complications. So you need to do something else for them. For those people, you got to see why he is not compliant. To do that, you should do a sleep endoscopy. So we already seen enough of a sleep endoscopy. Sleep endoscopy will tell you the problem is retropalatal or retroglossal. So basically, it is classified into retropalatal or retroglossal, and then the palate. There are two types of surgeries are there for palate. So there are circumferential collapse, what we have seen today. So there is a circumferential collapse, and there are lateral collapse at the level of the oropharynx. These two contributes to the main. These two are the main contributors for the retropalatal obstruction. So when you get a retropalatal obstruction, the most common side is the patient. You can do a single level, or if there's a multiple level, you do a multi-level surgery. Okay, so the palatal surgeries are further classified into palate sparing and palate splitting. The people who love palate and people who hate palate. So palate hating surgery or zetaplasty. Zetaplasty is creation of a zigzag mucosal flap on the soft palate and stitches to the lateral wall. So dissection and repositioning of the palatopharyngeus and the palatoglossus muscle, this reinforcing the shape of the oropharynx and restructuring the widening of an airway with a reduced collapsibility. So you remove the as morning our Srinivas Kishore showed, you got to remove all the mucosa, butterfly shaped mucosa over the palate, remove all the mucosal glands, remove the supra tonsillar fat pad, split the uvula, take it laterally and stitch. This is called a zetaplasty. So after doing tonsillectomy, you mark like a butterfly and remove all these mucosa with the fat, with the mucosal, submucosal minor salivary glands. Then remove the supra tonsillar fat, cut the uvula and stitch it lateral to the pterygomandibular laphae. Give you a picture like this. Okay. So what happens when you split the palate? You have there won't be an uvula left behind. So the secretions from the nasal cavity goes to the palate, above the soft palate. Through the uvula, it reaches the posterior pharyngeal wall and travels inside. If you disconnect these two, it may get stuck on your palate's superior surface, can stay there, giving you a globus-like problem, or you can have a foreign body sensation, mucus staying there. Patient finds it difficult to clear the mucus. So you can, now they are doing the surgeries are palate sparing surgeries. The commonest surgery what they do is an expansion sphincteroplasty, where you define the palatopharyngeus muscle, cut its upper 1/3, lower 2/3 junction, pull that muscle and stitch it to the pterygomandibular raphe. So this retains uvula. If the uvula is still very big, you can just reduce the uvula size, but you need not remove the uvula. So this is the you cut the palatopharyngeus muscle, bring it into a tunnel and stitch it to the pterygomandibular raphe. Okay, so then as you see in the morning, taking bite itself is very difficult, but applying sutures are much more takes time, and it is difficult. To avoid that, you can use the barbed wire, what is commonly used in the laparoscopic surgeries, where you need not suture it, you just pull it, it will get tightened at one direction, will not go back. So that's called barbed wire expansion sphincteroplasty. It's a muscle preserving, minimally invasive. So you need not suture it so much. So barbed sutures or VLOC or Stratafix, it comes from the Covidon, and it anchors the posterior pillar and the soft palate to the pterygomandibular raphe and the pterygoid annulus. Lifts and stabilizes the soft palate and the lateral pharyngeal wall without muscle cutting. And the technique avoids knotting or tying. So barbed sutures hold the tissue in place through their design for 3 weeks, and before that the scar will form, and with the vectors it will suspend the palate better. Okay, so this is the barbed pharyngoplasty. This you can see, you can take another bite here to pull the uvula facing anteriorly, and you can suture. Once you have finished suturing, you can see there will not be much of a raw area. So this is the video. I'll take another 2 minutes. Okay, so you can take 1, 2 or 3 stitches on the palatopharyngeus muscle and put it into the pterygomandibular raphe. You go again. So you do it on 2 sides like this. This is the final appearance of the pharyngoplasty. Okay, so the advantages of palate sparing surgeries are uvula contains enormous seromucinous salivary glands, playing a key role in the lubrication of the both speech and the swallowing. Preserving the uvula is therefore important for maintaining pharyngeal airway muscle tone and the normal physiological function. The patient undergoing uvula sparing surgery reports fewer issues with the foreign body sensation, globus, frequent throat clearing, and the pharyngeal irritation. Neither veropharyngeal insufficiency nor the nasopharyngeal regurgitation are noted as the uvula is preserved. Then why are we still talking about zetaplasty? As we said, now we are all almost everyone is talking about septoplasty. But still when you take classes or do surgeries, you do SMR. Why? Because best results are with a uneven full septal correction, best results are with the SMR, not with the septoplasty. The chances for recurrence of the obstruction are more compared with the septoplasty compared with SMR. Similarly, zetaplasty gives you very good results, but gives lot of complications like functional complications like velar-pharyngeal insufficiency, altered speech resonance, swallowing difficulties, and post-operative morbidities like increased pain, increased recovering time. But one advantage is all these patients are all little on the obese side. So when the patient has got a pain, he will not swallow for 10 days properly, might reduce weight, and it can contribute to the betterment of the that OSA. Risk of infection, wound adhesions, bleeding risks are all higher, and uvula destruction or shortening may impart the protective function of a uvula on the speech and swallow may compromise. So palate sparing surgeries preserve the soft palate anatomy and the muscle function, offering effective airway stabilization with fewer complications than traditional palate splitting surgeries. This is a sleep deprived phase. When we are deprived of sleep, we look like this. Thank you. As we are, as I have concluded my talk, we are about to honor two important people. One is the present director of UIORL. Other one is the previous dean of Viluppuram Medical College, and who was the professor of Shankar Subramaniam when he was a UG. So first we are happy to call our director, Dr. Suresh sir, to felicitate, as he is retiring next month. This is high time. We should felicitate. I call Shankar on stage. Thank you very much, sir. And as I don't tell this, my small talk will not become complete. He is my guru, who has taught me all my basic surgeries, holding my hand when I did my DLO. He is my my immediate senior. So thank you very much, sir. Thanks for everything.
Sir. கல்யாணத்துல எனக்குள்ள போடல நான். They made so many attempts for getting that. So it's a wonderful occasion, and Anthony chose a different place to honor me, and I'm thankful for that. I'm thankful for Shankar, who gave us this opportunity to have a common platform, right? Anthony, we all know, Professor Anthony is a great personality, right? He's a crowd puller, he knows, and he is an voracious reader. And someone has addressed him encyclopedia. We can go for Wikipedia also. And Anthony is more than that encyclopedia of ENT. And yes, on so many occasions he has told that I am his guru, and initially I resisted certain things, but then now at the end of my career, I always feel this hierarchy should be respected. Hierarchy should be there, and Anthony is guru for so many people around. See, Shankar is really honoring Anthony with such a great event here, and this should go on, because every other time when you do some surgery, it is our seniors who made so many other sacrifices, so many things. We started our career with the ordinary headlight, and we reflected light. And what our present generation is saying is something phenomenal. So all the sacrifices made by my seniors, I remember here, and I thank Almighty for this wonderful, wonderful event. Thank Anthony for remembering his guru. Thank you.
And next person is a very important person who is UG chief for Shankar Subramaniam. But Shankar Narayan sir is my friend, philosopher, guide. When I was working with him in Kallakurichi in PHC services. So every time he used to guide me. First he said, go write the account test, then departmental exams, and then next he'll say that results have come, go and see. Even that entrance exam I wrote 1 year back, results came after 1 year. He only told me, go and see what happened to you. Then I went and saw that, then I realized I had a MSc ENT, so I come and join here. He has got all the rights to shout at me, and he often shouts at me also. But still, whatever I do good in my life, it's all because of his advices. So we'll honor you, sir. So on this occasion,
I know it's getting late. This inaugural function followed by these things is taking your time. So Shankar Subramaniam was one of my prized undergraduate student. Subsequently, he called me one day and said, so there's an option of taking MS ENT, can I take it? I said, it's good, you take it. Then subsequently he said, I've been allotted to Stanley Medical College. And Anthony was there, so I said it's a good thing. In a way, Stanley is better. You will get a lot of material. So that is how he went to Anthony, and the rest is a long story which you have been repeatedly hearing. So myself, Anthony and Suresh, we were 3 together in MMC. So it's a mutual thing, we pat each other. So he gets recognition by recognizing us. That is how we work together. Thank you, Anthony. Thank you, Shankar. It's been a real pleasure to be here this day at this part of this function, a wonderful program. A young person has got the courage to come forward, take the pains to organize such an event. And these youngsters, they have a network. They have people who come out from outside and help them. So they are all encouraging, and you got that good strength of people who have done this wonderful workshop. It's possible. Thank you. Thank you once again.